You're tuning into the Active Mom Podcast with physical therapist, Dr. Carrie Pagliano, a real mom's guide to all things postpartum return to workouts after baby. If you're a postpartum mom, coach, trainer, or physical therapist looking for answers on how to get back to running, CrossFit, yoga, Pilates, HIIT, you name it, without the fear of pelvic floor issues or doing something wrong, this is the podcast for you. Let's start the show. All right, our next guest is gotten her PhD since the last time we checked with her, Dr. Christina Prevett. She has her PhD. She's a physio that used to be in Canada, then went to the US, back to Canada. One of my favorites to follow on Instagram. We DM all the time, CrossFit, women in sports, just trying to make the world a better place. Thank you so much, Christina, for being back on the show.
You're welcome. I feel like I talk to you every day, Carrie.
I know. And really, I said this at the beginning. I was like, really, this is totally selfish because I just want to physically talk to you instead of just DMing you all the time.
Yeah, we were trying to figure out when we were going to really meet in real life so that we weren't just internet friends.
I know. We're still working on this. Like I still say that like my favorite people I have not met yet. So
there's the bad of social media, but there's also the good, which is
there is the good.
Like you.
Yes, definitely. And so big things this year for you. You've got this new fun paper out that finally is starting to look at lifting resistance in pregnancy. And I feel like our whole profession has been like cheering to be like, hey, we're finally getting this in writing. So give us the quick down and dirty, like what made you kind of dive into this? Who'd you pull in? What did we learn? Where are we going from here?
Yeah. So my PhD is actually in high load resistance training in geriatrics. So not even close or remotely related to the paper of high load resistance training during pregnancy or the impact of heavy resistance training during pregnancy. But when I got pregnant with my daughter about 5 years ago, I was a competitive weightlifter. I had done CrossFit and powerlifting for so long. And being the researcher, especially in resistance training, somebody who was a barbell athlete for a really long time, of course, I went to the research.
Yeah.
And one of my committee members is Dr. Stu Phillips. And he said, if you want an area where there isn't any research, go into resistance training in pregnancy because nothing exists here.
No.
And he was right. And so we were kind of in the weeds and we've kind of been in the trenches of trying to figure out how do we best support these athletes who are resistance training, not even just our elite athletes, our recreational athletes who love lifting weights and want to continue lifting weights when the research just doesn't exist.
Right.
And so to kind of give context in pregnancy, this is a very protected time, right? In a woman's life where the consequences of a bad decision are very dire. And so if we don't know, the answer is no. And right now I'm working on a systematic review on resistance training during pregnancy and trying to look at the prescriptions of other intervention studies that we have in the literature. And my goodness, it's way more underdosed than any of our older adult literature.
I believe it.
Seated exercises for 16 weeks. Resistance training with a max of 3-pound dumbbells or 1 or 3-pound TheraBands, doing nothing that would load the core musculature. And we just also didn't have this big and growing group of women that were saying, I refuse to accept that, right? Like that's just, we have to kind of recognize that the research is generally a little bit behind clinical practice. It goes in both directions, but CrossFit and powerlifting and weightlifting really has boomed in the last 10 years.
Right.
And it's probably been even less than that people who are pregnant are like, well, I'm going to keep doing this, whether my providers are telling me I can or I can't. Yep. And so that's kind of how our paper started. We had to show first, with the literature being here, right, of saying, well, you can resistance train, but the max that a person has lifted in a research trial so far is 10, 15, 20 pounds. And we're going to do an RCT where you're lifting 200. I would never get through an ethics board. You would never get through that.
That's a valid point.
So the first thing you have to do is say, guess what? There's this big group of people who are doing it, and let's kind of try and see what their outcomes were. And that's where the survey was. And so I emailed Margie Davenport, and she's been on this
Love
podcast.
her.
I know.
Yes.
I love her. She emailed back this random physiotherapist who was doing a geriatric PhD who said, I have this idea. Would you help me figure out how to do it?
Yeah.
And we pulled in Marlies DeVivo, who is very instrumental in some of the UK pregnancy guidelines. Lori Forner,
Love
she's
her.
in Australia. She's
Yep.
amazing. I get to meet her in real life very soon
Yay!
at ICS. And Miranda Kimber, who's a member of Margie's lab. And we were able to really blast this on social media saying, the first step we need is to show that there is a group of individuals who are doing heavy resistance training, and let's see what your outcomes were. And now our next step is, how do we follow women forward and get prospective data on people who are getting pregnant and continuing? So now we can have an idea of, are they lifting this or are they lifting that? Are they modifying? What does their outcomes look like during labor and delivery? What is their baby's outcomes like? And what is their postpartum return look like? So how do we follow people forward? But this type of stuff takes so much time, and we need to have the background information. So we have this survey now that says that people are heavy lifting. We're working on this systematic review that says, there's a big gap here. We don't have anything that even I would consider moderate intensity as a resistance trained athlete. It would definitely be moderate intensity for some who don't have that same exposure.
Yeah.
But, 20 pounds for my athletes who are squatting 250,
it's nothing
going into their pregnancy is not a sufficient stimulus for them to
it's
continue.
laughable. It's laughable.
Mm-hmm. Yeah. And I don't want to put like the other researchers on blast. Like it is, we do have to kind of take this stepwise progression, but we now have this overwhelming and growing group of women who are like, this is not sufficient for me.
Yeah.
And I really need the answers.
Well, you have a couple really good points, I think, that you raised. And one is to remember history. And your kids are now how old?
4 and 2. I can't even
Oh my God. Well, it feels like yesterday you were just posting on all the stuff you were doing with your 2-year-old in pregnancy. Because my kids are a little bit older. I feel like I was in that generation that I remember those lighter recommendations because women were not lifting. And I think that's a really important point. I think, Christine, you kind of brought it up in Up to Speed, where women weren't doing marathons, women weren't doing Olympic lifting. And then they were, and then it was just a matter of women being in that space. And then it was a matter of women continuing to be in that space, stepping up, and then throw in life, pregnancy, all of that. And I think if you don't pay attention to that, you can easily sit here and be like, well, why isn't there research? Because we weren't freaking doing it.
Yeah.
We weren't doing it. But then the next point I think is so important to understand, and I appreciate you making research accessible, is we can't just start with that. We have to start with, people are doing this. Now let's look at the gap. Now we can move forward. Those steps have to be laid in the research in order to get to where we're going. You can't just be like,
yeah. And it's so funny because people will say, well, it's a cross-sectional survey, Christina, like these internet people who are like being these gurus and saying that the research isn't good. And I was like, one, you should try and do it yourself.
Yeah. Good luck.
18 months to get out a survey into the research, but also like you have to understand the research process that we grow our levels of evidence based on the accumulation of evidence that builds on each other.
Yes.
And so we need these foundational pieces, these surveys, these Delphis, these qualitative studies that are looking at what clinicians are doing in practice, even these clinical commentaries that technically aren't research studies, to build this interest. And trust me, it's happening. Like, I'm talking to Linda McLean's who are looking at pelvic floor morphology. I'm following the Janet Shaws and Ingrid Nygaards and Carrie Bowes who are trying to build it, and they're coming from different angles. Like it really is coming. It takes time and it takes diligence and precision. And so we are building. It's just not as fast as we would like.
I think it's an important thing to understand. And I totally admit, I am one of those people that, a Caribo paper comes out and I'm like, yep. And you're looking for that thing where you're like, this is going to alter my practice. This is going to, and the thing is, we're still in that foundation building, and this has to occur. And for those of us who would like to go faster, we just have to be patient. And I think it took me a while to realize that, like, these are the steps. This is the groundwork that has to be laid for us to get where we're going to go.
Yeah. And we're starting to see like some of the stuff coming out of Carrie Bowes' lab is things like what is happening from a pelvic floor perspective pre and post resistance training.
Yep.
What is happening for our nulliparous or nulliparous, depending how you say it, those individuals who haven't delivered or given birth.
Yep.
What's going on in their pelvic floor when they're resistance training for several years?
Right.
What's happening in our exercisers who haven't had children? And then what does obstetrical history have to do with some of our pelvic floor dysfunctions? Like that evidence, again, is starting to come up. And then what are the differences between the Valsava maneuver? Because if you're talking to a cardiologist, holding your breath for 15 seconds with your nose closed and your ears closed and just looking at your hemodynamics. If you're talking to a pelvic floor physical therapist, it's bearing down like you're birthing a baby. If you're talking to a resistance trained individual, it's abdominal bracing. And so we're trying to coalesce all of these things together and figure out the terminology and make sure that everyone's on board, and then hybrid them all together. And then when you're pregnant and now you have hemodynamic changes, you have maternal cardiovascular system changes, you have resistance training changes in terms of anthropometrics, and you're having pelvic floor strain. Now it's like,
what do you do with all that? Right. Exactly. And I'm so glad you brought that up, because that was literally one of the things I wanted to ask you, that I do think, especially for people, maybe primarily physios that work in this space and are working with lifters, but may not lift themselves. I think it's very easy to do, this is good, this is bad. Unpack Valsava versus bearing down in a language that would be most relevant, I think, to like a physio or a trainer or something like that.
Yeah. So really cool. I'm actually writing a clinical commentary right now that speaks to this. And talks about how to put this into your pelvic floor evaluation and kind of pieces this out. Yeah, you're welcome. It's hopefully going to be published in the next couple of months. But okay, when we're looking at Valsava, in a traditional sense, this is the the production of force against a closed glottis, aka you're holding your breath and generating pressure in your belly. What's going to happen is we're going to have this sharp increase in blood pressure. That's going to happen. It's supposed to. And then your blood pressure is going to drop. Your heart rate is going to go up, and you're going to see an increase in pressure throughout your body. This is going to happen in your brain. This is going to happen in your eyes. This is going to happen in your thorax. This is going to happen in your belly. And what that does is it creates stiffness across the system. That's an advantage in resistance training. Mm-hmm. So when we are doing this for kind of switching from cardiovascular changes to resistance training, why we are doing that is when we have this increase in pressure in our trunk, it's going to get all of our muscles around our core canister to fire a little bit more. And so that's going to make our trunk more stiff. It's going to allow us to produce more force, and therefore it's going to make us feel stronger. Gotcha. And there's a really seminal paper that was released in 1992 that said, once we're over about 80% of our 1 rep max, at least transiently, we are going to hold our breath.
Right.
And we see this all the time in our new moms, right? Who are holding that car seat coming in. They're taking a couple steps, holding their breath and going, and that is a Valsava. And so it can be demonized as something that is bad because of the next piece, which is how we consider Valsava in pelvic floor rehab. But we do it all the time, whether we realize it or not.
Yeah, of course.
And so for pelvic floor rehab, we use the Valsava or bearing down as a part of our prolapse assessment, where we get a person to strain down as if they were going to birth a watermelon or birth a baby or have a bowel movement, whatever terminology you will use. And it's basically a range of motion assessment of the vaginal walls. That's the way I kind of picture it. And so when you think of this term Valsava, where we're starting to go is that Valsava in and of itself is for cardio.
Right.
What are the hemodynamics of Valsava? When we're thinking about it with resistance training, we're talking about abdominal bracing. And when we're thinking about it in the realm of pelvic health, we're talking about straining. And when we change that terminology to the true hemodynamic Valsava maneuver and then abdominal bracing and then straining, now we get a little bit of a clear picture about what we are trying to look at, what we are trying to investigate.
Right.
But because the use of the word Valsava has been, 1, associated with high blood pressure, 2, has been associated with straining, when we try and translate that into resistance training, light bulbs go off, like flags start to go up and say, well, no, no,
Right.
no, 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 because this is bad, because I don't want your blood pressure to go up, especially if you're pregnant. And I don't want you to strain on your pelvic floor because it's already
Yep.
stressed. And so there's been just like this like turf war around semantics that
Yep.
we've really had to kind of tease apart. And now that we're getting on the other side of it, the beautiful thing is that we can start to really learn a lot about how to best support our athletes who are peeing when they are lifting weights.
Yep. Yep, that makes a lot of sense, and I think the other thing that comes along with that usually in conversation, you mentioned earlier breath holding, and typically when I'm working with pregnant and postpartum moms, I wanna understand what they were taught, and I also wanna be clear that what they were taught wasn't wrong. And I think that's important too, that like you may need to play with things in a moment and then be able to change to a different strategy and whatnot. But again, the whole idea that, moms are taught, oh, breath holding's bad. And then they're like, but I was taught this and I lifted this long. But again, people not in that space, just like you said, like if you're going to get close to your 1 rep max, you're going to hold your breath. Like, I'm sorry, but unless you've been next to that barbell and tried to lift that barbell, which is why I think every physio should lift a freaking barbell.
100%. Or
Um,
just try to lift a heavy couch if you don't want to
yes,
go your barbell. Lift a heavy couch and
exactly.
tell me what your breath does.
You have to. I'm sorry, there's no way around it. So thank you for clarifying that because I feel like those are two things that get really like, good, bad. And I do think it is getting better now than it was, say, like a couple years ago. But that I feel like lots of times in pelvic health, we have these words that we use to describe things and then they're used differently. And in the research, it must make it really hard to do studies because people use the words in different ways and it's not seamless. It's not consistent.
Yeah, exactly. And that's why I got asked to write this commentary about how do we start to clear this
Yeah.
terminology up so that we can really go forward and
Yeah.
learn. And you are when you're working with somebody who is leaking, whether they're pregnant or not with resistance training, there's a lot to learn from a standing assessment about how they are bracing.
Mhm.
Because the other thing that we see is that there are some individuals who were taught how to brace by inhaling and then bearing down into their belly,
Yes.
right? A lot of men can brace that way. I still don't think it's the most efficient pattern, but they don't have the same rates of pelvic floor dysfunction that women do.
Mhm.
And so, that bear down or that straining when you're supposed to be bracing. Now,
Yep.
again, we have this terminology that are you bracing or are you straining? Because if you're straining, then the first thing that I'm going to do with you is to teach you to move from a straining strategy
Mhm.
to a bracing strategy.
Right.
And if I'm doing an internal assessment in standing and I ask you to brace like there's a heavy barbell on your back and my finger pops out, then I
Yeah.
know
Yep.
that you're potentially using a less efficient pattern that may
Yep.
make you more vulnerable to peeing under heavy load. And the
Yep.
first thing we can do is start clearing that up. It's a beautiful thing.
Right. And that's where I think you're gonna love, hopefully one of these days you get yourself a real-time ultrasound. That's so freaking fun to play with in standing, to look at pelvic floor strategy and to look at abdominal strategy and watch those recruitment patterns and see what it translates to what you feel. And it really, that was probably the first thing I ever learned with ultrasound when, because back in the day, I don't know if you were ever taught this. We're like, oh, TA, when TA contracts, it'll pop into your fingers. Bullshit. Like, no, that's internal oblique. Like, I'm sorry, it just is. And I'm not that anybody died because, that's what I was taught or anything like that, but it's just wrong.
Yeah,
And
it's so funny. We spend so much time in the low back pain literature trying to get TAs to turn on, and then we realize that
we're
it's
not even doing the right
gonna just
thing.
get the
Yeah,
core stronger. And I feel like pelvic floor is just like, 10
I
years
know.
behind with the imaging and prolapse and low back pain, like that similar
Yes.
discordance. And then we're gonna see the same.
We are. We're like, I was having this conversation earlier today. We're talking about like, like rando running things. I think we were talking about like barefoot running, how that was like that was like the cat's meow years ago when like Born to Run came out. And then now all of a sudden it spilled over into like, pregnancy and postpartum. I'm like, why are we 10 years behind everything?
Right. So I was at Linda McLean's lab in the University of Ottawa, and she's doing real-time ultrasound. She's doing some work around using ultrasound and doing assessments in incontinent versus incontinent runners.
Fun.
And you would just love what's going to be coming out of her lab. But as soon as she was showing me some of this ultrasound, I was like, oh my gosh, could you imagine if we did a study that looked at bracing versus straining? Like, how
You have
beautiful
to.
would that be? Like, I was like, how do we get this to happen?
You
I was like
have to.
messaging Shafali Christopher and Rita Deering. I was like, how do we do it? Like, trying to like bring in the troops around how to.
If you need to borrow a body, I'm right here for you. So
I know.
awesome.
Absolutely.
No,
Have
but
you played
again,
with it on your own? Changing Valsava versus a brace?
oh yeah. No, it's like it's one of the, and that's the thing. Like you can start to turn your body into like little party tricks. That's what I do with my diastasis and coning and doming and that sort of thing. Like you really like, oh, if I do this, it does this, and
Oh,
it's
yeah.
really fun to watch yourself. You really have to make sure that you don't spend too much time like ultrasounding yourself. So I have a very sad story related to that. Don't, yeah, I might as well share it. I actually caught my own miscarriage on an ultrasound. So that's also why you should not necessarily do your like ultrasound yourself all the time. It's totally fine. It's one of those things I suspected it. And then my friend, I was like, hey, so he's like, yeah, no good. So if you only ultrasound yourself, this is like who's that guy that ultrasounded his wife like every day? Crazy guy, Tom Cruise. Only ultrasound yourself for musculoskeletal purposes. That's our disclaimer today.
Disclaimer. Yes, absolutely.
That's our disclaimer. All right. Moving on. There was another thing when I was reading your paper that it just like sparked the myth of you address resistance training in supine.
Yes.
Okay.
Yeah. So when we were talking about the questions I'm sorry, I didn't even.
No. Just go.
So when we were looking at how to generate the survey, we were talking to, Lori in Australia and Marlies in UK, and we're like, what are these myths that we see?
Yes.
And we didn't even capture all of them. So one was, can you lift in supine? One was, can you Olympic weight lift? Can you hold your breath? Were kind of the big three. Yep. Another one that she had brought up that we actually didn't even bring into the paper was, can you lift overhead? I didn't even think that was another one that some people think that because of the load being over your head and the demand on your heart to lift a weight over your head, again, like something.
Yeah.
We are resilient. I think that we can lift, but some of these things that get perpetuated as like usually bad cases of telephone or, being overly on the conservative end.
Yep.
But we were just trying to say, okay, what are the things that we hear in clinical practice? What are the things that sometimes come into our research guidelines, clinical research guidelines?
Right.
And can we do subgroup analyses on these people that avoided supine exercises versus didn't, who Valsava during pregnancy versus didn't, that Olympic weightlifted versus didn't? And are we going to see any differences in the rates of different complications? And we tried to investigate as many different complications that could potentially be associated with these things as we could. And then we just had to see what the numbers shook out to be, because sometimes, if everybody avoided supine exercise, we wouldn't have enough of an N value in that group to be able to compare. But thankfully, we were able to, in each of those subcategories, we were able to kind of tease them out.
Now with supine, the primary, resistance one I'm thinking is, bench. Were there any other ones that kind of popped up?
We didn't ask about specific exercises. We asked about, did you exercise in supine? But that could have been anything like glute bridges or any type of abdominal exercises on your back. And bench press was the big one. This is so nuanced, but the hard part too is that if you have a power lifter, they're not actually flat on their back when they're bench pressing.
Right.
When you pin your shoulder blades back, you're actually in this bit of an arch, which would, in my mind, actually take weight off of that vena cava, that blood supply. And so I would actually think that risk in a true bench press position would be even less than if you were doing something like
completely supine,
bridge. Yeah. But I think this just gives the nuance that, one, it is safe to exercise on your back.
Yeah.
But if you are feeling dizzy, unwell, don't feel good, then we're going to pull you up to an incline and get you doing incline bench press instead. And, I've had clients that are immediately symptomatic, like are warming up with a glute bridge. And they're like, I feel like I'm going to throw up. And I was like, get off your back.
That's what I always say that. And it's always the first time moms, because it's right up there with like deli meat and things like that. I have a friend I went to PT school with who's Greek, and she's like, you can't tell a Greek woman she can't have feta. I was like, fair game. But like my happiest moments at 41 and a half weeks with both my kids, I would wake up flat on my back because I could breathe. I was like, I can breathe. And I'm like, trust me, you're gonna know. You're gonna know if it's not right. And then we just change position, but we scare the crap out of women
Yeah, and we don't like the rates of clinical supine hypotensive syndrome is actually quite low. It's just, again, we want to make these recommendations to make sure that we are trying to mitigate risk as much as
Right.
possible. But the messaging doesn't tend to be, here's my empowerment knowledge for you. This is what you need to know.
Yep.
It's let's scare you so that you don't do it. And so
Right.
we were hoping with this paper that we were going to start pushing back against the fear focused messages and start moving towards the empowerment
Well,
messages, and I think it's important.
it's such a nice way to do it though, because it's not like, two middle fingers up, lay on your back, go for that. It's like, hey, this is what people are doing. This is what happened with it. And, for now, draw your own conclusions. But like it seems to be that people are doing pretty okay. So let's actually talk about the findings. Let's kind of run through those kind of questions and what were the findings that you guys came up with.
Yeah, absolutely. So we could touch on the Valsalva maneuver. And what we saw was that for those that continued to Valsalva during their pregnancy versus those that didn't, we did not see any increased risk of fetal maternal delivery outcomes, that we didn't see any variation. We also didn't see an increased prevalence of pelvic floor dysfunction postpartum in those that continued weightlifting versus those that didn't. Now, some people have misconstrued my paper and said that Valsalva is protective. That is not what I said at all. It
Mhm.
said that the risk was not higher in those that Valsalva versus those that didn't.
Gotcha.
And so our paper grows on two research studies that have looked at the hemodynamics of doing Valsalva during pregnancy. One was at a 10 rep max leg press, and the other one was an incline bench press up to
Yep.
50 pounds, and showed that there was no shunting of blood away from the placenta. There was no adverse fetal heart rate responses during Valsalva. And now our paper was able to add to that literature and say, well, at least cross-sectionally, those that continued Valsalva to perform Valsalva did not have worse outcomes. So they didn't have any increased risk of gestational hypertension, preeclampsia, that higher blood pressure response that we
Yep.
try so adamantly to avoid during pregnancy. Like that didn't contribute to any sort of blood pressure issue. And then another thing that people say is like, your pelvic floor is under so much strain during pregnancy that we should avoid the Valsalva because it's putting extra pressure.
Mhm.
And that didn't kind of pan out in the postpartum period. What I used to say 3 years ago, Christina used to say is don't Valsalva during pregnancy. And now I say, here's a range of breath
Right.
options to use. And what, some's going to feel better than others.
Mhm.
And guess what? If you can Valsalva versus breathe with exertion versus free breathe, if you're a CrossFitter, you're going to be so much better at Metcons because you
Right.
can cycle a barbell better without your heart
Right.
rate going so high, which will go higher in using a Valsalva than in free breathing or exhaling during the lift. So I give more like these are options for you based on
Yep.
how you're feeling versus being a little bit more of a backseat driver with respect to my recommendations on how to manage the
Right.
exercise or when you're navigating it yourself. So that was one thing that came up. We saw in general that individuals who continued heavy lifting had lower rates of pregnancy related complications. So we saw a decreased risk of gestational hypertension and preeclampsia, gestational diabetes as compared to national averages, which again, we would probably assume that that was true because we know that individuals who continue
Right.
to exercise during pregnancy tend to have lower risks of things like high blood pressure and gestational diabetes during pregnancy. That does not mean that they are immune, but that we're stacking the deck in our
Right.
favor. I don't want people to think that there's no way I'm ever going to get this, so they're disappointed if they're doing all the right things and then they get
Right.
high blood pressure. But again, Valsalva has that increase in blood pressure. And so the thought is, well, maybe it's going to cause a risk for blood pressure to be high. And that's something that's bad during pregnancy. We didn't see that in our study. And then rates of perinatal mood disorders were lower postpartum. So lower rates of postpartum depression and anxiety than individuals or compared to national averages. We
Gotcha.
didn't have a control group. We were comparing to national averages. And so that was something that was really positive as well that we
Mhm.
saw with the paper. Again, we see that people who are more physically active tend to have this protective effect around
Right.
um, things like mood disorders across the lifespan. But one of the things that I think could be a potential confounder there is that CrossFit also has this community tribe
Right.
piece, like we couldn't possibly tease apart those that were resistance training and it was like the strength training that helped, or was it you were strength training in a box
with your
or
friends.
in a gym
Right.
with all your friends, and you see all those postpartum videos of like coach holding baby and mom trying to get a little bit of a workout in, and like all of those things.
Yeah.
So those were some really big highlights. And then postpartum, we started to capture a little bit of information around when people started to get back, when they started holding their breath again for lifting, and when they started using a weightlifting belt again.
Mm-hmm.
So the mean was 12 weeks. And as soon as I say 12 weeks, people are going to say, wait, 12 weeks to start strength training. And so that was the mean, which means that we had 2 standard deviations below.
Same deal with running. We had the same conversation.
Yeah, right. Above and below the mean. So 12 weeks was the average. And then about 4.5 to 5 months was the average that people were starting to hold their breath again with lifting. And between 5.5 and 6 months postpartum, people were using weightlifting belts. And now we haven't tested that out to see, is that the most appropriate time? We're just kind of characterizing what a big
information is.
Did.
Yeah.
But it gives us, some guideline to see what's the next step. Like, how do we test out this protocol and see, maybe when is the right time to start using a weightlifting belt? When's the right time to increase Valsava? What is your body ready for in that postpartum period to start giving us some return to sport guidelines?
So with this group, with the survey, what was the average number of years of participation prior to pregnancy?
Oh my gosh, it was a wide range.
Yeah.
I think we had people who were, oh my gosh, don't even quote me. I think I have some of the paper guidelines up here now. In terms of how long, age of first delivery was about 30, which is pretty consistent on first delivery with our national average. I actually do not remember how many years. It was several years though. These were not new lifters.
I got that impression. And that was kind of what I walked away with was, if you had been doing this for a while, and if you were on the heavier side of lifting, you were lifting more through the duration of pregnancy, you were more apt to participate sooner. That was just kind of the gut feeling that I got after reading the paper. And like, I don't think this would necessarily apply to like your newbie that's like, hey, they just started working out at like 6 months for 6 months and then they got pregnant. Like that's a very different athlete than somebody who's been actively in the gym for 6 years or something like that.
So our pre-pregnancy numbers, we asked about their weights, and it was almost a 200-pound squat, 120-pound bench. Their deadlift was 105 kilos, so average was 230 pounds for the deadlift.
So these are strong girls.
Right. They're people with resistance training history. And you're right. I think that's important, right? Because we want, like, they have comfort with these movement patterns.
Yes.
And it makes no sense to these people that have, been doing this for 3 years. And they get pregnant. They're like, okay, so you want me to stop doing all of the things that I do for exercise? We see the same thing in running for people who that clock a lot of miles pre-pregnancy. They're definitely more likely to continue running during their pregnancy than those that didn't. And they're more likely to get back. Some of our elite runners are running again at 4-5 weeks. Like that study that just came out around elite runners, they're at like 75% of their pre-pregnancy volume by 12, 14 weeks. Where some guidelines are like, some people are saying you can't do anything until 12 weeks. And they're like, hold my water. I've got a couple miles to do.
I know. And that's where I have this conversation with people. I'm like, you would expect that elite athletes would have the best guidance. And the fact of the matter, they have even less than the average recreational athlete, because they don't have, like, half the time they can't get a study that meets the criteria, because you're not supposed to like do studies on pregnant women when their heart rates are above certain points. Right. And they're like, oh, well, this is just, that's zone 2 training. Like super easy. Right.
Yeah. Well, and then, so thankfully, like, Margie's group just came out with that paper around high intensity interval training that got them up to 90% of their VO2 max and showed that there wasn't any blips in fetal heart rate responses, that they actually saw an increase in heart rate response, which is so cool that we're seeing that aerobic training in mom is actually doing a little bit of aerobic training with babe, which is cool to see that, again, that narrative is starting to change.
Yeah.
But getting across an ethics board is tough when you're saying, like, I really want to push these pregnant women, where the idea, like the
Right.
societal idea, not even the science-based idea, the societal idea is that there's some fragility there
Right.
that we need to protect.
Yeah.
And so it can trickle into, what we can get away with from,
Well, and yeah, I mean, that's where I give so much credit to the women who were kind of the pioneers doing that, because you know how it feels the first time you're pregnant. You don't want to do anything wrong. But if they've been in the gym for a long time, that's who they are. And you know your body ideally, and you're not going to do anything stupid to harm your baby. But at the same time, like, it takes some kahunas to be like, all right, no one knows. I'm going to just keep going. And clearly this has been happening for years enough for, to you, because you had how many people that answered your survey? It was a lot.
679.
Yeah. Yeah. I mean, easily within like a couple months, 679 people lifting really, really heavy. Clearly the culture has shifted there, and you're just quantifying and just
Yeah.
reporting on it and being like, no, this is what's been going on.
Yeah.
Now let's go back and look and see what's up. So
Yeah, absolutely. So, personal story, when I was pregnant with my daughter, I had a big weightlifting meet that was a couple months out, and I was trying to qualify for nationals again. And so I got pregnant, and I was in pelvic health. Like, I did postpartum exercise programs. I was fairly educated, I would say, in this space. But I remember the first time I tried to snatch. So, if you're not familiar with a snatch, weight from the floor, contacts hip. I had just found out I was pregnant. And I started to cry in the gym because contact sports is contraindicated during
right.
pregnancy. And so I was like, does this count? Like, I'm technically making contact. And thankfully, I had a high risk OBGYN that I knew.
Mhm.
And so I was able to call him, and I was like, what do you think? And he's like, your abdominal, like, baby's so far back
Yeah.
in your pelvis.
You're
Your
fine.
abdominal wall is so, like,
Right.
used to that contact point. Like, that is not like you falling when you're like, if you're a new snowboarder and you're like tumbling down a hill. Like,
Right.
those are totally different things.
Yeah.
And I was so thankful for him because I was 10 weeks postpartum. I was still using a weightlifting belt. I PR'd my snatch at that competition, and then I told everybody that I was pregnant, right? Like,
Whoops.
immediately after. But the only person that knew was my coach at that time, who was freaking out that I was, 10 weeks pregnant competing
Right.
at this event. But, those types of things are what prompt people to be like, I'm not okay with this being the standard. And
Right.
so when I was doing a PhD in geriatrics, I messaged another researcher in a completely different field, and I call it my research side hustle. And now, we're starting to be able to develop more and more research in this. And
Yeah.
it's so amazing to be in the pelvic health space right now.
Oh my
I
God.
know
Yes.
everyone feels like it's so slow, but it's so
No. And
it's like,
yeah.
gosh.
And that's where I this year I have really reflected on how far things have come, because I think I've been in this 25 years now. That was 25 for those of you in the back. No, and not for nothing, my son's going to be a teenager in a couple of months. He's going to be 13, and you do some reflecting, and I was like, we really have come light years. And as frustrating as it gets when you hear people spewing nonsense, there's just as many, if not more, people that are spewing good evidence and putting good stuff out. And like, I can't even keep track of what papers are out because there's so many. And that was not a thing even 4 years ago.
Yeah.
Even it just
It's
wasn't.
so cool. Yeah, it is unbelievable to see. I've been in practice 10 years, and yeah, even that in that amount of time, how much has
Mhm.
come out to start
Yeah.
to push the profession forward.
Yeah.
And it's also a cool time because, it kind of is this growing group, largely dominated by women, who are getting, their PhDs, and that they're internally trained pelvic floor PTs. We have the Shefali Christophers, the Rita
Yep.
Deering, the Granier Donnellys, like
Yep.
Ray Foreigners. Like, I could just go on and on. Linda McLean, like, all
Yeah.
incredible voices that are just doing so much. And, like, Margie is still fairly early in her career. Linda is too. Like,
Right.
they're also pushing people like the Jenny Krugers. Like, there's so many
Yep.
names where they are one, they have done so much pioneering work to help set the foundation.
Yep.
And they are bringing partners in such a collaborative way
Yep.
to be able to start expanding and working together. Like, I have not reached out to a single researcher in this space as somebody who does not have a PhD in pelvic health. And they're like, yeah, let me help teach you. Like,
Right?
let us collaborate. Like, how can I
Yeah.
help you? Like, how do we figure this out together?
Yeah.
And it's so amazing because you don't see that in every space in research. You don't see that, in pelvic health sometimes. And so there's just
Yeah.
also this big change towards collaboration.
Yep.
And it's just so beautiful, like to, be able, like, just like you said once to me, you're like, if you ever need anyone to help with research, like, I'm in. Like,
Sign me up.
right? And I've had so many people reach out and say, like, how
Yeah.
can I help you?
Yep.
And that's just amazing to be in this space at this time. And
Yeah.
for our patients that are pregnant at this time, I think we just have so much more empowerment focused messaging than we had before. And it's
Yeah. Well, and there's baby booms in running, there's baby booms in CrossFit. Like, I think that's the other thing too, is the visibility. There's so many kind of spearheads that are just aligning. Like, this really is, I feel like it's a renaissance right now. It really is just this wonderful space to be in. And in some ways I have FOMO because it would be really fun to be kind of going through this with a little one again, but I'm not that stupid. Um, I'm just not, and I'm tired. Um, no, but at the same time, I think it's such a beautiful place to sit back, knowing where we came from and knowing how simple and how few answers we had and what we were trying to do with nothing. And it's because of pushing forward in research. It's because of clinicians pushing forward and, asking questions. It's because of these pro athletes being open about their stories and being open about trying to get back and whatnot. Like, it's so much that's moving this forward. And I think, if you have a daughter, you're like,
Ew.
okay, all right,
Yeah.
this is my gift.
Yeah. And like, how do we, and even just the pelvic floor space within athleticism.
Yes.
Like, we had that systematic review, speaking of kiddos, in female adolescents, that 43 to 48% of female adolescent athletes are leaking, right?
I
Estrogen high state in
know.
puberty, estrogen high state in pregnancy, and high and low, like the extremes of estrogen are going to relate to higher rates of pelvic floor dysfunction. We could go
Yep.
lots of tangents on that, but if we said that percentage and we replaced leaking with pain, we would be
Right.
just enraged that
Yeah.
we have,
Yeah.
50% of our female baseball players have pain in their shoulder. And people be like, why are we not doing
Right.
anything about these athletes? Like, what's going on with their coaching staff? What's going on with SNC? And our coaches know nothing about the pelvic floor.
Well, and
They don't know, how do we get to them? Like, this was a big topic at Female Athlete Conference in
right.
Boston. It's like, how do we get our coaches involved in the fueling needs, the menstrual cycle, some of these things that are unique to female athletes
Right.
that are influencing their performance, and on the other side are making them get out of sport.
Well, and
We know that. Yeah.
this is the thing, like, that I don't think I was aware of. So my oldest is a boy, my youngest is a girl. As my son got older, he doesn't play baseball anymore. The boys would have pitch counts. Girls in softball don't. What the hell, right? So, like, if
Pitch counts. I'm sorry, I have no idea what that is.
okay. You can only pitch a certain number of times in a game. And so if you're on a couple of teams, so down here, typically if you play on a travel team, you usually play rec too. So if you're pitching for two different teams, they're keeping track of your total pitch count per day, per week, because they don't want to hurt anything. That's all fine and good for boys. Boys have a pitch count. Softball, gigantic pitch, no count. They can. And I was like, okay, how can we have a conversation about periods and hormones when you guys can't even talk about shoulders?
Yep. Yeah,
And like,
absolutely.
I had no idea. And I'm sitting here watching my daughter's friend just pitch, and I saw her do a double header. I'm like, why is she still out there? And like, oh, there's no pitch count. I'm like, what?
Right. Yeah. So these discrepancies that we're seeing between the
It's
genders in
it's
sport.
inequity. It is not discrepancy. It is inequity.
Yes. Yes, you're right. And how do we address it?
Yeah.
And so, like when I was at, so Female Athlete Conference was in Boston, Massachusetts.
Yep.
It was this huge multidisciplinary conference. It was incredible. And they were even saying, 10 years ago, the thought of having a conference that was specifically tailoring to the unique needs and considerations of a female athlete was unheard of.
Not a thing.
To have, that much attention on female athleticism. And
Yep.
now we have the FIFA World Cup that's bringing in more viewers. Like the finals brought in more viewers than the men's final did. We've had volleyball games for women's volleyball games that have had sold out stadiums. And, we're really starting to see this push towards female athleticism. And at FIFA, they just announced the big female athlete project.
Yes.
That Margie and Sinead DeFore are going to be part of the pregnant postpartum piece too. And they've been working on for a long time. And what a beautiful thing. Like they had maternity leave policies, they had breastfeeding policies, they had all of these things. And so it is starting to change. It is slow. And we have so much work to do.
But we're going somewhere. Like I think WTA, I think I saw something with World Tennis because a colleague of mine is involved in that too. I think that's going in the same direction as well. And again, like it's just a waterfall effect. And it's frustrating because again, you're like, okay, we have so much more to go, but dang, if we're not kind of, making those steps forward, which feels really good to kind of be in that space. So my next question for you is like, okay, you finished this PhD, you've got geriatrics. So we kind of alluded to this a little bit before we pressed record. Pregnancy, postpartum, geriatrics. There's this funky little space in the middle.
Yeah.
How do you feel about that?
Yeah.
It's menopause.
I love it. So
it's a trash can. It's a dumpster fire.
No.
What are we going to do about it?
I know. I have to do about 8 more PhDs, but I would get a divorce if I do any more school. So I'm going to have to do it as
sure. Yes.
Yeah. So, when we take a zoom out and we look at the female lifespan, I've kind of alluded to this earlier, is that when we have estrogen high states, we have increased risk of pelvic floor dysfunction. So adolescence, puberty, and pregnancy are those 2 very high estrogen states in the female lifespan. On the flip side, when we have the estrogen low states on the other side of the spectrum, pelvic floor dysfunction also goes up. So postpartum, when you are lactating, you are actually in a very similar hormone profile than when you were in menopause. And then obviously going through the perimenopause, menopause transition. And so my big, hairy, audacious goal that I guess I will just declare to the rooftops about where I want to go is that my life goal is that I would love to see this lifespan approach to the interaction of resistance training, pelvic floor dysfunction, and physical function across different hormone states across the lifespan. So I would love to see, some of the work that we're doing on high load resistance training and the interaction with pelvic floor dysfunction and physical function really like span over to the menopausal transition as well. So are we seeing an increase in support or a decrease in support around the pelvis during pregnancy, postpartum? What do we see for individuals who are postmenopausal who are resistance training? Is that the same as somebody who took on resistance training very recently versus somebody with a 10-year barbell history? I'm sure my pelvis, as somebody who's been resistance training now for 12 years in 2 pregnancies and 2 postpartum journeys, is going to be different than somebody who hasn't had that same history. And, how do we map that out? And, I've talked to some menopause researchers in the last little while, and that's the hard part, is that there's so many variables in the menopause piece because what we're starting to see is, of course, age is a risk factor for so many different conditions, including pelvic floor dysfunction, but it's starting to be a bit more nuanced than that, where we're seeing, is it chronological age or has it been age since your menopausal transition? So has it been years in a low estrogen state that are more predictive than the actual age on your birth certificate? And, they're going to be closely related, but somebody who goes into menopause at 50 versus 54, those are 4 years where you're in potentially a higher estrogen state. If you took hormone therapy, that was very controversial for a while until we got the research on that. Now hormone therapy is more widely accepted. And then we have certain risk groups that it may not be indicated for, which is where the research is kind of teased out. Are they going to have the same profile as there's just so many different pieces to how do we serve individuals during menopause, and then how do we serve them beyond? Like our older adults with frailty, like incontinence is one of the leading causes of institutionalization.
Absolutely.
individuals who are on heart meds like diuretics, we know that they stop taking their meds when they have to go out anywhere because the diuretics make them have to pee so bad that they can't be that far from a bathroom. And all we've done is say it negatively impacts your quality of life and you stop taking your meds. And yet we haven't done any type of intervention study to see,
Right.
can we conservatively manage some of those symptoms with urge suppression techniques or those types of things to learn how to help with that bladder outflow
Right.
problem? So there's just so many questions on the other side. So how do we bridge some of these concepts across the lifespan
Mhm.
to be able to see this interaction between resistance training as a modality, pelvic floor dysfunction, and physical function? Because we know that resistance training to physical function is massive. We
Right.
know that strength is never a weakness. You never go into any part of your life and say, I really wish I was weaker in this moment. It would have made my life easier. We don't. And so we try to get as much muscle mass as we can
Yeah.
and hold on to it for as long as possible.
Yep.
But then how does that link with pelvic floor dysfunction? So we're
Yeah.
telling people not to lift heavy weights because it's going to cause them to have pelvic floor issues, but you need to try and be as strong as possible for the
Right.
lifespan. So there's like this mixed message that's starting
Yes.
to happen, and how do we start to iron out those details?
Oh my gosh, there's so much good stuff in there. Like one of the things that just popped into my head, when we're talking about Renaissance too, is there has been this big conversation now, kind of debunking all the hormone stuff. And I distinctly remember because that was like 2000, and I started in PT in 1999. So that was like right around that. I remember my mom, she watched what the heck her name was on the Today Show, and it was like, okay, then we're screwed for hormones for 20 years. And a colleague of mine here in DC, Rachel Rubin, she's very vocal about getting women estrogen. Like I think there were some articles in the New York Times, like just being like, hey, we need to have this conversation about hormones. And I think it's also because of genitourinary symptoms in menopause, which really should just be genitourinary symptoms, period.
Period.
Related to being related to having estrogen as a primary hormone.
Yes.
So I feel like that's kind of part of this too, but there's also this big push lately to get more information because we have moms that are more active going into perimenopause and menopause. And we have a lot of people again spewing stuff that doesn't make sense and telling you, oh, you should exercise in relationship to your cycle. And people don't really have a reliable way of tracking hormone levels or
And the research
you,
doesn't support that.
no, exactly. That's don't get me started on that. And then you should eat at a certain time or eat here or do this or do that when you switch into perimenopause and menopause, because this is when things, and like, again, we don't have data. What was, oh gosh, I can't remember who it was. It was Kirsty Sales that did the review.
Christy Elliott Sale, she's
Yes.
just another gem. Yeah.
Right. Oh my God.
Amazing. I could listen to her talk all day.
I know. I know.
Kelly
And so,
McNulty was the other one. She's now
yeah.
Kelly McNulty did stuff around period health, and she was the one who was the lead author on the systematic review around exercise and menstrual cycle phases.
Yeah.
And now her postdoctoral work is actually looking in menopause. And so, yeah, so she's kind of transitioning into menopausal work,
Oh my
and she's been
God.
like
I'm in
really,
love. I'm
yeah,
in love.
just
No, because I'm literally sitting here trying to figure out like who to follow. And the people that are putting stuff out that's accessible right now, I know it's not based on the data.
yeah.
It's not based on the data. And it's very disconcerting sitting here at 47 being like, I don't know what the hell to do, which is kind of eerily reminiscent of, hey, oh, I don't know, about 13 years ago.
I know. I know. And it's almost like all of these women who are pioneering for themselves during
Forget to do it
pregnancy and
again.
postpartum need to, yeah, exactly. They need to do it again now
Doing
that
it
they're
again.
approaching menopause. And
No, it's totally that. It's totally
yeah.
that.
Yeah. And
But
so it's going to demand
yeah,
more
well, at least
research.
we're practiced. I mean, it's not our first rodeo. But the other thing that I have been doing is because I do work a lot with runners, and as you well know, runners tend to be allergic to strength training, barbells, things like that for the most part. Um, and I have been planting the seed to say, hey, you might want to think about this because we do have good data on heavy weights improving performance in running. So, worst case scenario, you get started sooner. And I was thinking of this when you said, your pelvic floor, where you've been resistance training for a long time versus somebody who had just started. What is that going to look like at later stages? If we can get, if there is a benefit there, what if we start having these conversations a lot sooner, introducing heavy weights sooner? Could that set us up for something much better later on. So I'm totally extrapolating from that. And I'm going to completely, what's the word I'm looking for? I'm going to just infiltrate my runners and bring them over to the dark side.
Well, it's funny because again, like I'm just kind of, this is where my brain is going and I'm trying to think about research studies is when we transition into menopause, when we go into this estrogen lower state,
Yes.
we're not estrogen absent, but we're estrogen lower.
Mm-hmm.
We kind of have this shift around our pelvis from static support where our ligaments were very, very much involved in a lot of our feelings of support around our pelvic floor and our vagina. And we switch more to a dynamic support where, that estrogen affects the collagen of our ligaments and we need that pelvic floor muscle training or that muscle strength in order to feel that support. But we also tend to do less as we transition through menopause, through life, because life happens. And so we're losing some of the static support, but we also don't have the reserve in our dynamic system to match that balance shift. And so if we keep the reserve in our entire body strong, when we start to lose that static support, will we feel it less conscientiously? I'm not even talking objective. I'm talking subjectively. I don't know the answer to that. My hypothesis would be that the stronger we are, the less we need to rely on our static supports. And we see that in the arthritis research. We see that in a lot of our research, but we haven't really evaluated it in pelvic and menopause. So
do you just like sit home and like throw ideas on like legal pad after legal pad and like how do you sleep?
My husband says I'm exhausting, but I don't know if that's just him saying that.
Well, I'm just like, you have all these great ideas and you just literally need like this like lab full of minions to just make it so. You're just like, do this, do this, do this. Like,
yeah, and I just need the mentors to help me like make the research studies as succinct as possible. And that's where like having mentors like Marky is just so great. They're like, she's like, Christina, I need to bring you back a little bit. Like, let's focus on this one.
Right. But that's when you just need to clone her and then be like, all right, well,
how do we clone your brain, Marky?
How do we do all of this? But it does. It takes a village to put Christina's ideas to work. That's all. But you've got but the really cool ideas because you have, the understanding of all these different stages and hormone states and resistance understand. Like it's just a cool. Like I could just sit here and let you just spew on time. It's like I would just like. Break these things down
I feel very thankful to be a research scientist. Some of my background is I actually went into my PhD for fun. I didn't actually go into it because I wanted to go into academia. My husband, again, he thinks I'm ridiculous, but I just had this research question that I wanted to answer around, I was having frequent flyers on my program and I was like, how do I try and create this preventative model of resistance training and reserve? And then that translated into how do I create this reserve within our pregnant people? But it has given me this wonderful gift of knowing how research works and then blending it with my research space. And so I feel like I get to be this knowledge translation bridge that gets to be involved in the research, but also give that research to clinicians in a way that's hopefully digestible. And it's very cool to be able to be there. And it's hard because there's so many researchers who are so busy that it's hard getting their information in front of clinicians. So I'm so thankful when they do podcasts and things like that, because I get to be privy to their conversations, about some people are thinking in the running literature that it's not actually the pelvic floor supports, but the position of the urethra postpartum that's a determinant of incontinent versus incontinent status in runners. And I was like, well, that's fascinating. And it was just because I was talking to this researcher resistance training and about resistance training and the parallels. And so how do we get those conversations out and then get the clinicians to be like, well, that's really interesting because I've been doing ultrasound and I do notice that it's harder for me to find the bladder neck on individuals who are incontinent versus those that aren't. And, does that blend in? And there's just, it's cool.
And that's just dealing with that tiny little wheelhouse there. You start pulling in, if you look at any of the kind of like return to run tendinopathy, kind of that kind of stuff, there's stuff we've got to pull from there too. Cause I swear a lot of pelvic floor stuff is lower extremity driven. I joke that the pelvic floor is the mom of the body. Like everybody else is like, I'm not doing it. And some new people are like, all right, fine, I'll do it. Like it really, like, I really do believe that. Like, they just pick up the slack for everybody. But to your point, like, again, the more that we, I think, can hear other conversations and hear what other people are thinking, it inspires us to kind of look and pay attention and be like, well, what about this? And keeps that inquiry going. And I do appreciate, one, that you are in the gym. And I think that makes such a big difference. Two, that you had the vulnerability to share so much of your second pregnancy on social media. I think that was just perfect timing. And again, took a lot of kahunas, because I know you probably got some crap from a lot of people being like, well, you shouldn't do that, you're going to kill your baby, that kind of stuff. But then 3, being gracious enough to share not only, the hard experience of, working through research in an area that's kind of adjacent to other stuff, but then kind of pulling it all together and gifting it and gifting that conversation to us. So that's why I love you, but whatevs. All right.
It's been so great.
It's been fun. It's been fun. I'm just going to say, like, I don't even know how I found you. I just, it's all good. Good love to Alexis too, by the way, who's been on the show with us. All right. So because I feel like you've done the questions before at the end of maybe I didn't do them until, maybe I started them after you guys were on. I changed them up a little bit. Book you're reading or podcast you're listening to right now.
So up to speed, I've actually been reading. So Christina,
yes,
I'm reading right now. And the podcast that I'm listening to is Big Little Feelings. I listen to them. They're a parenting.
Oh yeah. I saw your
story today. Started a podcast, and
I saw that.
So I'm like obsessed. I just love everything about them. So those are the book and podcast.
Love it. I am currently listening to Lori Forner's podcast, and she's doing like a Mythbuster thing with Taryn Huam. And so that's what I just dove into.
I just saw her podcast with Michelle Lyons too. It was wonderful.
Oh, I have a lot of questions about the vagus nerve.
Yes.
I think we talked about this. I was like, oh, we're going to find some funky stuff because COVID and the vagus nerve are not friends.
Yes.
And those of us that deal with the vagus nerve and pelvic pain and kind of all the other stuff, I have a feeling that we're in for some changes.
Yes, I think.
Yes, I think so.
So I think Lori.
I know. I need to get on the bandwagon there one of these days here. Okay. So who should we know about? You threw out I feel like you answered this question. Like you threw out 70,000 names, and I'm going to have to go back and write them down.
I must sound like a name dropper.
No, so it's perfect for me because I'm going to go and Google stalk them and then ask them to come on the podcast.
Yeah, do it. Yeah. So in pregnancy and postpartum, exercise in pregnancy is Margie Davenport's lab. Totally. So research that's coming out of there is really, really wonderful. In terms of researchers that, I really follow, Janet Shaw and Ingrid Nygaard, Michelle Matola, Linda McLean's lab, which is MFM lab online. They're starting to get more involved in the research space. They are all I could name a million researchers. Period of the Period is Kelly McNulty's lab or page. She was doing the work on exercise training during pregnancy, and now she's kind of doing some stuff into menopause. Are maybe 5 or 6 people that are just wonderful follows if you're looking for evidence-informed information.
That, which I think is incredibly important. Find those people, follow them. Okay, and then this question, it's like one piece of advice for new moms, but I want to caveat this, one piece of advice for moms. Maybe they're pregnant right now and they're worried about lifting in pregnancy and postpartum. Where do you start with them?
Yeah, this is such a loaded question. I think that the piece of advice I'm going to give you is that strength is not a weakness, and I am not afraid of your pelvic symptoms. Nice. We would never be postpartum, or we would, let's kind of take a step back. I would never expect you to come back from an injury and come back to take 6 weeks off and then come back to full range of motion, full function, and be completely pain-free. And yet we tell moms after a C-section to go back to exercise after a big surgery and say, you should have full function. You should be completely pain-free. And if you have any symptoms, you're going to ruin something.
Yep.
And so I tell my new moms that when we are trying to get you back, especially to sport, you are demanding a lot of your body and you're going to hit thresholds. And that might mean that you feel heaviness or leaking or pain. And I'm not afraid of those symptoms. You did not ruin anything. We are just figuring out where your thresholds are right now so that we can accumulate volume underneath those thresholds and build those thresholds up.
I love that. I love that. And I think that's so important to take the fear away, because it's scary and people want to do what they want to do. And if they think that if they notice something, then that's it, that can be killer on your mental health. But to have somebody on your team that says, I ain't afraid of this. I love it because it's like, hey, this just gives us more information and this just tells us where we need to focus now.
Absolutely. You paint my room, like when we're doing barbell squats. Great. Now I know when your threshold is. Let's bring some up and let's figure what you did. Hopefully I got it on video so we can take a look.
Right? Oh my God. Love it. Love it. So get yourself a physio who will let you pee in the room while you're lifting a barbell.
Yeah. Get a physio that has a barbell in their room, or at least is looking for your videos.
Girl. Okay. That's a whole nother conversation. I have to admit, like I've been in my space now, it'll be almost 6 years in February. And the beauty of initially it was like this very kind of like warm, comforting place. And now I'm like, it's so filled. Like if I ever have to leave here, my garage is just going to be full of like so much equipment and weights and boxes and all of these things that I never ever would have thought as a pelvic floor physical therapist that I would have. But it makes me happy because when women come in, they know that they are seen. They know that they are in a place that is not going to deny them or be afraid of their stuff, which I like, which I love. Cool. All right. If you want to find out more about Dr. Christina Prevett, she's like, should I put my PhD on my name? I'm like, yes, you're going to put the PhD on your name. You earned that bad boy. You can find her on Instagram at dr.christina_Prevett or at the Barbell Mamas. Thank you as always. It's a pleasure. And again, one of these days, I know. Okay. 2024, we are definitely doing the in-person thing. I am putting my foot down and saying it's going to happen and it will happen. So have fun at ICS and all that good stuff. So congrats on your PhD and can't wait to see what paper or commentary comes out next. Thanks for being on the show.
See you.
Did you enjoy the podcast? If so, leave us a 5-star review on iTunes and tell a friend to do the same. Register now for the free on-demand postpartum mama masterclass, how to overcome the 3 most common return to run mistakes. You can skip to the good part and get back to running while missing these mistakes. Find this and more free resources under the patient section on carriepagliano.com. This podcast represents the opinions of Dr. Carrie Pagliano and her guests to the show. The content should not be taken as medical advice and is for entertainment purposes only. Always consult your healthcare professional for any medical questions.